to be here and hopefully share some interesting information with you. Um, I really have four takeaways or four goals I want to try to communicate with you today. And I hope to give you a lot of ideas and inspire you a little bit rather than put you to sleep and bore you to death. So I'm going to really try my best to kind of be entertaining, informative. Also, I don't see the chat box. So at this point, if you have questions, I'll have to take them at the end is my guess. I left about 10 minutes for questions and about 20 minutes for content. And I really designed this presentation for families and people who are just not in the, I think, everyday world of behavior analysis. So I hope you find it, like I said, like this great young lady who's getting inspired rather than this group who is going to sleep. I always like to start at least with context of talking about autism a little bit. So right now you can see there's a 178% increase in the rates of autism since 2000. And now the new rates are 1 in 54. So this is just like tremendous amount of kids that are being obviously diagnosed with autism. So what we know about this is that kids are being diagnosed earlier and that autism is not just something in the United States. It doesn't really, the rates of autism do not vary very much when you look at states in the United States. So Massachusetts has a high rate, Michigan has a high rate, Florida has a high rate. Also, when you look at the rates of autism across other countries, you see these rates as well. So this is not a unique phenomenon. It's my mother is 80 years old and she's this tiny Italian woman. And she says, Stephen, everybody has autism now. And one of the things we know about autism is that it's a very reliable diagnosis. So when you do get the diagnosis, it tends to be the right diagnosis. And the reason is that when people say they're overly diagnosing kids with autism, usually those diagnoses are right on, and they're getting kids younger and younger. So what an interesting study, I found this interesting at least, is this 1 in 54 rate could be an underestimation. There was a great article in Pediatrics 2018 that suggested that possibly the rate of autism was 1 in 40. So this 1 in 54, prevalence rate could be an underestimation. Now, I've been doing this for 25 years, even before there was really a certification to be a behavior analyst. And I remember that people had all kinds of reasons for why kids had autism. At one time, people thought it was parenting, which we know is completely bunk and not true. Another reason was that it was plastics, that people were absorbing too much plastic in their systems. The other reason was the microwave. Then the brain was too big, and then the brain was too small, then there were too many mirror cells. The fact is that we really don't know why these prevalence rates are growing at the rates they are. Dr. Fred Volkmar out of Yale University has been studying this. The only thing that he suggests we really know is there is some tendency for it to run, there's some overlap in siblings, and that individuals with autism also tend to be associated with seizure disorder as well. So we know it's neurological. And then we also know that we're just much better at making the early diagnosis. One of my favorite researchers is Dr. Phil Peck out of the University of Texas in Austin. And she believes that we could diagnose children with autism as early as 6 months. And she is a big advocate of the early diagnosis because the earlier we can get to these kids, the better. Autism is at least it's one of the diagnoses that is, I guess, amenable to intervention. So early and effective intervention, I think, is in everybody's best interest. So with that, something else that I find interesting about the treatment of autism is about 43% of children who are diagnosed on the autism spectrum receive what is considered behavioral therapy, and that 7% are on medication only. Now, when I look at this, like 43% of kids getting behavioral treatments, It bothers me because it tells me that close to 60% of kids on the spectrum are not receiving behavioral therapy. Now, there's wonderful therapies available for parents. I think behavioral therapy is generally thought as the gold standard for children on the spectrum, but only about 43%, according to the Pediatrics article in 2019, are getting behavioral therapy. So a lot of that is because our profession, the profession of behavior analysis, do not have enough behaviorists to serve all of these children. And then with the growing rates of autism, we're just not catching up. So it's a field, it's a growing field, and there's just a tremendous need throughout the country. We just opened up in Los Angeles, and I thought, wow, we're opening up in Los Angeles. It's a very metropolitan city. There's a lot of behavior analysts there. But within the first 2 weeks of opening up, we have like 60 referrals for families waiting for services. The same thing in Massachusetts, because in Massachusetts, you have the highest density of behavior analysts than anywhere else in the world. But as soon as we were available to treat children, we were just flooded with referrals. So there is just a tremendous amount of children who really need this service, and families as well. I'd like to start with the core deficits of autism. Obviously, our kids have three hallmark symptoms: the social deficits, the communication deficits, and then behavioral excesses. I bring this up because the purpose of this talk is to talk about how we're going to develop interventions for children on the spectrum. So I think that whenever we start to think about the core symptoms of autism, we have to think about what interventions are going to be effective for those core symptoms. Something else is that our kids learn differently. I was very fortunate that early in my career, I worked in Boston. Massachusetts was one of the few states that was highly, they had lots of funding for young children with autism. This is going back even as much as 20 years ago. And so a lot of research came out of Boston and also Yale University. One of the things that we know about our kids when we teach them is they have a difficult time with sustaining eye contact. They don't learn vicariously or through observing others the way that typical kids learn. They also have a hard time reading social cues. One of my other favorite studies by Fred Volkmar is that he did a study where he used Google Glasses and he put it on children with autism. And when people were talking to children with autism and the children would look at people, they only were looking at their mouth. They were missing all of the other sort of nonverbal social communication and cues that was going on. So the other problem we have is that early on, our kids are not responding to name, and also that the naturalistic interventions that a lot of parents do with their children don't seem to be effective. So it's really easy to identify these kids early on, and we have to start teaching them these skills because they're just not picking up things the way that our typical kids would, because they almost seem socially disconnected from the world in a sense. So having said that, there are four things that I want to talk about when we talk about treatment plans for behavior analysis. Number one is, if you're a family member, I want to teach you how to look at your behavior plan and look at the goals that are being developed and whether those goals are appropriate for your child. The other thing I want to talk about is identifying something called a behavioral function, or when we see problem behavior or we see a behavioral excess, we understand what the function of behavior is, and I'll explain that because it's critically important. The next thing I feel like parents need to know is how to develop something called functionally equivalent replacement behaviors or interventions. So we don't want to just get rid of problem behavior. We need to replace it with something that's useful and functional for that child so that they could survive in society. We'll talk about that as well. And then the last thing I'm going to talk about is generalization. Some behavior analysts are so talented, they can get a child doing a lot of wonderful things with them. But unless they can do it with the parents, and unless they can do it in a regular classroom, and unless they could do it at church in the community, it doesn't matter. So we need to make sure that our treatment programs transfer out of the treatment setting and into the natural environment. So that's going to be the focus of what I'm talking about here. The first thing that we do is behavior analysts will usually do an assessment with the child. So the assessment really involves a family interview, child's observations, and then they complete some sort of formal assessment. I think it's really important during the interview that parents understand that they have to bring their priorities to the assessment. I'm going to tell this story. I'm a storyteller. I once got a big contract in the state of Connecticut, and I was going to be the first ABA autism provider in the state of Connecticut. And the individual who was in charge of the Birth to Three program had a rule. And the rule was, hey, if you're going to go into a parent's home and provide in-home early intervention services, you always have to ask the parents what they want to work on that day. And I remember I had my PhD, I was a lot younger, and I said, well, I know exactly what I want to work on. I want to work on social communication, social deficits, and behavioral issues. So, but I'm a rule follower, and I was going to do the first assessment. So when I went in there, I remember asking the parent, what would you like to work on today? And she said, you know what I really would like to work on? If you could teach my child how to give me a kiss in the morning. And what it made me feel like was I was so arrogant, I think, as a young behavior analyst, that I thought that I knew more than the parent knew about what was important relative to a goal. And it had a huge, like one moment like that had a huge influence on my career. And I realized that she was 100% right. I probably taught that child how to kiss his mother within, I would say, 2 to 3 sessions. And that mother ended up being one of my best allies in terms of working with her child. Child made tremendous progress. I say that because I really think it's important that parents tell us what the goals and objectives are. You know, now we do want those goals and objectives to fly around the core deficits of autism, social deficits, communication skills, and behavioral issues. But the more that we can find out the priorities of the family and listen to them, I believe the better the programming is and the more success for the child as well. So when we listen to families and we write up goals, typically in a treatment plan, you'll see something like this. Now, here's some goals for increase. So this is an overall goal for social increase. If you notice that the domain is social, and then there's something called the long-term goal, or the LTG. For this one, it says Johnny will increase his social skills over the next 6 months. That is completely okay. It's a totally general goal. It almost means nothing except that we're working on social skills over the next 6 months. But underneath those goals, parents need to start looking and saying, what are the short-term goals that the behavior analyst is working on? We all know what the long-term goal is, that we want to teach him social skills, but how are we going to do that? And this is where you open your treatment plan, and you should be looking at the short-term goals. So I'll just read the first one to you. I'm not going to read them all to you. It'll say Johnny will greet people by saying hello in 9 to 10 opportunities with accuracy across 3 consecutive settings, across 3 people and 2 settings. So what you have there is a very specific, we're going to teach him hello, and we want him to say hello the correct way 9 out of 10 times. So, and not only that, we want him to do it across 3 consecutive settings with 3 different people and in 2 different settings as well. So what we really want to do here is be specific. There's something called the stranger's test in behavior analysis. And what that means is that if a family or a stranger could not understand that goal, it's not a good goal. It's not a good definition. So we need to have programs that are easily comprehensible to families, and something that they understand and something that they think is important. And a good behavior analyst is also working with families to connect these short-term goals to the long-term goal. Yes, this is the starting point where Johnny's going to start developing social skills. We're going to start with hello. We may go to handshaking. We may go to raise your hand. We may go to asking for help for others, how to play with others. But a lot of this falls within the social goal. And usually behavior analysts are measuring these things. So when we look at something like, so here we're looking at the hello goal that I just talked about. There's two conditions. Number one is like, well, this graph shows us the number of times that Johnny will independently say hello. And you could see that in the baseline condition, we're collecting information because we want to know where he's starting. So, but then during the treatment condition or the intervention condition, what we're doing is we're measuring how much progress he makes. Now, this is a pretty simple graph, but families need to be able to understand this graph. I think that behavior analysis is something called the show me field. In other words, if I develop a graph and a family cannot understand the visual analysis of it, it's not a good graph. It has to be something that's easily comprehensible to families. They understand it and they can tell if their child's making progress or not. So this is how we do it. We should be communicating with our graphs and with our data, not with our, let me tell you how he's doing, because we really need evidence here that he's doing well. I always say that if we're not making progress with your child, we have to find somebody else who can make progress with your child. And our graphs are the best way to show families what's going on. So my next slide is, we also typically work on a communication goal. Again, the long-term goal is Johnny will increase his communication over the next 6 months. That's okay, it's a very general goal. But then the short-term goals tell us how we're going to do that. And again, these short-term goals have to be something that's comprehensible to families. So we can look at the first one. Johnny will ask for help in 4 to 5 opportunities in the absence of tantrum behavior across 3 sessions, 3 people in 2 settings. So again, we want him to ask for help. I think we all understand what that is and we measure it. Our next goal is usually to decrease some level of problem behavior. I highlighted the one on the bottom that Johnny will decrease the frequency of self-injurious behavior. I can't read it because I have a window open on the side of my computer, but I think it says from 10 instances to 0 instances across 10 consecutive sessions, people in 2 settings. So again, these are easily measurable. They should be graphed and they should be something that's easily comprehensible to families. The other thing that I think is really important in designing intervention is what is a behavioral function. Now, you don't want me as a behavior analyst to get just rid of problem behavior. You have to replace it with a socially acceptable behavior. And that's because all behavior has a function. And what that means is we need to look at behavior as what is the payoff. It's a question that says, why is the child engaging in the behavior? What do they get out of it? And that's a very different concept for some professions. So here's Johnny, and I just got this is not really Johnny, this is some kid from Google Images. But if you look, when we have tantrum behavior in psychology, some people will say, hey, look, this person has anger control issues. This person could be anxious, or this person can't control their emotions. Now, those are all real things, but in behavior analysis, we don't look within the person to explain behavior. When we see tantrum behavior, we look at what the function is or how the behavior pays off. So we see Johnny tantruming, and when we look at this, we say something incredibly practical, such as, well, Johnny engages in this behavior because he gets attention from mom, or Johnny engages in this behavior because he gets to escape the grocery store because he doesn't want to be there. Or Johnny engages in this behavior because every time he does it, he gets a cookie in the grocery store. So when we look at this, we have to look at what is the function or the purpose or the payoff of the problem behavior the child's engaging in. And if that is not very clear in your behavior treatment plan, it's a very difficult thing to design intervention around. So we absolutely have to look at behavioral function. So again, with behavioral function, it could be getting a preferred item. the child could say to themselves, when I tantrum, I get what I want. In other words, getting a preferred item. Or what they learn is that tantrum behavior is the fastest and most effective way to get their needs met. So with that, we can go into intervention design. So we now know that, let's just say Johnny is at the grocery store, has a tantrum, and it's because he gets a cookie. So we understand that that's going to happen. Now, there's a lot we can do, such as not take him to the grocery store, but that's not very practical, and we just can't just avoid the grocery store for the rest of his life. So what we could do is teach him vocal behavior, such as requesting a cookie at the grocery store. It's a much more appropriate way to get the cookie than having tantrum behavior. So what we would do is we could teach him how to, example, ask for the cookie. If he's not vocal, we could teach him how to point to a picture of a cookie. We can teach him how to sign for the cookie, but we need to teach him a functional replacement behavior so he can get what he wants without engaging in the tantrum behavior. The other thing that we need to do is we need to teach that parent how to respond to the inappropriate behavior when Johnny is tantruming. So the easy thing here is that if Johnny was to tantrum, he doesn't get the cookie, we don't pay him off. Or we teach mom how to prompt Johnny so he will vocally request the cookie and then he can have it. So I say this, and I know it sounds very simplified, but I want you to understand the connection between the behavioral function and the intervention design. For every problem behavior, we can teach a functional replacement behavior. Those functional replacement behaviors are what is going to really help Johnny for the rest of his life. He's got to get out of this pattern of learning that every time I tantrum, I get a cookie, or I get what I want, I get attention. So this is what I think parents need to be looking for in their programming to make sure that we have functional replacement behaviors that are practical and then work for the child. And also that we're teaching parents how to respond to the problem behavior so that they don't get flustered during this process. Okay. Some more graphs for you. This is an example of a problem behavior with a replacement behavior. On my left-hand side, you'll see duration of tantrum in minutes. And you could see in the baseline condition that Johnny was probably tantruming for about 55 minutes per session. And then during the intervention, you could see that the tantrum behavior in minutes started to go down. Now, why did it go down? It could be because we taught him in the next graph requesting behavior. So if you look here, he didn't make many requests in the beginning, but then when we taught him how to request items appropriately, you could see that he made much more progress in the intervention phase. So the two work together. The graph on the left goes down and the graph on the right goes up because we're replacing tantrum behavior with something that's functionally equivalent and something that's going to work for the child and something that is acceptable to the community, obviously. So I bring this up. This is all very simplified, and I do it because I think it emphasizes the point that it's not about just getting rid of problem behavior. A good behavior analyst is there teaching functional behavior replacement skills so that this child can survive in the community and be a member of the community, and also just have a better quality of life at home than just engaging in tantrum behavior. The next thing is generalization. Generalization is, hold on one second, is usually one of the most, hold on. I'm trying to close a window. Okay, I did, so I can see my notes now. Generalization is usually one of the more difficult things to program into a behavior program. This is, like, I think, one of the most important topics in behavior analysis that's not talked about enough. So, and I'm not, let's say that you have a child with autism who goes to an ABA center, and all day long they're in a center and they're getting 40 hours a week of applied behavior analysis. Generalization means that the child who's getting serviced in a center needs a program so he could exhibit the skills that he's being taught in the center at home. Our kids don't transfer skills all that easily. Transferring of skills from one setting to the other is usually has to be programmed, and it has to be a place where you're teaching parents how to elicit those behaviors in the home. And so when we look at our kids, they tend to be a little rigid. They tend to have a hard time with transitioning. And just because you taught them something in one environment doesn't mean they'll transfer it to another environment. So even if I'm teaching a child in a natural environment like the home, they have to be taught how to exhibit the same behavior when they go to church or when they go to elementary school or grandma's house. So that's the most important thing to understand about generalization, is that it needs to be programmed across new environments, across new people, and it's very systematic. It's really important that we're not just working in basements with kids, teaching them skills, and then we're saying, okay, we're done, and then leaving the house without informing families what we did, what was working, and then encouraging families to be part of the session as well. The more that I can get families as part of the session, I usually will see much more progress with children as well, because these kids really need a lot of help transferring skills from one setting to the next. One of the things that I'm a big advocate about is something called daily routines. And that's where we try to look at designing interventions into the child's natural daily routines, so that intervention is happening all the time throughout the day. So when the parent is helping the child get dressed in the morning or put on their shoes or playing with them, they're able to continue the intervention in the natural environment and make it look very natural, so that these skills can transfer across all settings. So here's some generalization goals. I'm not going to go over this because I could tell I'm running out of time, but again, here's my generalization graph. Usually a generalization graph will have 4 phases. You can see that in the first phase, we didn't get, this is where the person may have been operating relative to vocal request. And then there's something called an acquisition phase, where we'll actually teach the child how to make a vocal request. And that'll work great with the ABA therapist. But then we try to generalize that request across 2 different people. And then the next phase is 2 different settings. It's really important that you understand that behavior analysis should never occur in isolation of the family. The family needs to be a big component of this, and a family needs to really understand what's going on. This is not a situation where, again, we're working in isolation in a basement, we're doing lots of drills, we're doing repetition, and then we're just leaving. So anyway, my 4 takeaways are basically, we talked about assessment of behavior relative to developing the goals, and the goals need to be measurable, they need to be comprehensible to the family, but most importantly, they need to be important to the family and their priorities, as well as the core deficits of autism. The next thing is that we need to identify behavioral function. We need to stop looking at behavior as always problematic and say, okay, here's a behavior. What's the function? What is the child trying to get out of this, or what's the payoff? And then thirdly, once we understand function and we understand what skills they need, we can create interventions. It's important that we're just not getting rid of problem behavior. We're teaching functionally equivalent replacement behaviors that can be used in the community and throughout the rest of their life. And then when we're teaching those interventions or those new replacement behaviors, it's important that we generalize them, not just with the ABA therapist, but with mom and grandma and the neighbor and in churches and in the grocery store and in schools as well. So with that, I really appreciate that. I hope I kept my time here, but I really appreciate the opportunity to speak here. I think this is kind of like one of the most important presentations that I potentially make. And I certainly can take questions, and hopefully I did a good job for you all.
Well, I could say you did a great job, Dr. Wolf, so thank you. If anyone has questions and they want to add it to the chat, we can start that process.
Bree, if you want to read me the questions,
Yeah,
I
of
see them
course.
in my chat for some
Yes,
reason. So.
I can take care of that. Well, maybe if there's no questions, you did an excellent job covering the
I don't think
material.
so. I always want questions.
I know.
So, yeah, I just did this presentation
Oh.
for.
Oh, go ahead. You can finish. There is a question, but you can finish.
Oh, nope, I'll take the question.
Okay. Is
Go
there
ahead.
an age that's best for behavior therapy?
The sooner, the earlier, the better. No doubt. That's why it's so important to get the early diagnosis of autism. I guess early in my career, when I was a psychologist in Florida, there was only funding for adults. And so I used to work with a lot of adults with self-injurious behavior, aggression towards others. And it was the hardest thing because they would have 30 years of practice of engaging in problem behavior until I would get there and try to change behavior. So we want to do this as soon as possible. There's some really good research, even like when children start to develop self-injurious and problem behavior, it's usually very young. It's usually between the ages of 4 and 5. So I want to get these kids as soon as possible. I think there's a lot of physicians who are hesitant to give the autism diagnosis early. In my opinion, if there's a question, I think we should give a diagnosis early so we can get in there and start working with this child. The research is pretty clear that the earlier the better. And usually early on, we want to do as many hours as we possibly can. The standard is usually between 30 to 40 hours a week. However, I think those, in my opinion, those hours need to be manipulated so that it accommodates the family system. So when we look at young children in therapy, they're usually in therapy for probably 2 to 3 to 4 years intensively. If your child's getting therapy for 10 hours a week, they're usually in therapy a lot longer, just because they don't get the number of hours until 5 or 6 years come around. Any other questions?
Yeah, is there an age where it's too late or a teenager question mark?
No, not at all. I worked, like I said, with adults. I've made tremendous change in behavior. I've worked with people who are, I'm working now in the state of Florida with somebody who's 62 years old. And those people need help and they need services, and it's not too late. I think that we have a lot of people who don't have a lot of experience with adults, but I always feel adults with autism don't get the services that they need, to tell you the truth. All young BCBAs want to work with young children, but there's a lot of work to be done with adults. So the answer is no, bring on the adults.
Yeah, great. What happened if there wasn't a diagnosis early on until teen and inconsistent interventions? How about when 15 or 18-year-old, what do you do then?
I think you have to get a good behavior analyst to come in there, do a new assessment, and just kind of look at the history of problem behavior. I take on kids who are, teenagers are tough because sometimes, they're out of puberty and there's other issues to deal with that probably a lot of behavior analysts or a lot of people don't want to deal with it. But there's tremendous progress that could be made with anyone from any age. The younger is better because you can help them develop language and early replacement skills so they don't practice problem behavior over a long period of time. It doesn't mean that we can't work effectively with teenagers. The only thing I might add is that, when we do have kids who are teenagers, it's really important to have the whole family involved in intervention as well.
More or less effective when a known genetic issue is a cause for autism symptoms. More or less effective when a known genetic issue as a cause for autism symptoms.
I used to work with quite a few individuals with genetic disabilities, mostly Angelman syndrome, Prader-Willi syndrome, that were clearly genetic in nature. And there's not a lot, I don't know if you're going to get those big gains in IQ that you see in the autism research for young children, but there's a lot that can be done. You know, I had a girl with Angelman syndrome who had severe pica behavior, and pica behavior is when you will eat in objects you should not be eating. And so at least we were able to protect her, because pica behavior is a really dangerous behavior. And we were able to replace pica behavior with something more functional. We actually taught her how to request lollipops and how to do other things to stimulate the oral area. So there could be a lot that we could do with genetic disabilities. There's a lawsuit right now going on in the state of Connecticut about behavior analysts treating people with Down syndrome. So we could improve the lives of people with genetic disabilities. I don't know if you see those big gains where somebody's going to be independent in the community. The other thing I always say, I try not to say this to my autism audiences, I always say that applied behavior analysis doesn't have an exclusivity agreement with autism. In other words, we have as a science a lot to give to just anyone who has some behavioral issues. Even when you look at the research with ADHD, when you look at the best possible combination of treatment is usually a combination of medication and applied behavior analysis. So, but we are so busy and we're so overwhelmed in a sense working in the autism field that we haven't been able to really get out there and I think work with some of these other diagnoses. Hopefully that'll change one day because I think our science has a lot to give. But right now, I think we're focused on, you know, helping children and families affected by autism because we're so good at it.
Thank you.
Okay, was that?
Is there any other questions? That was the last one that came in a few minutes ago. I do want to say thank you so much, Dr. Wolf, for your time today. We got you from Florida, so here we feel pretty lucky.
No,
so
no, I thank you very much.
Yeah,
no,
the person who asked that said that was very helpful. So thank you so much for being with us today.
Okay, no problem at all. Please send me feedback if you feel like there's, you know, to improve this presentation. I really appreciate being invited. I wish you all the best out there.
Thank you. It's insightful, and we'll put this up as a recording on our website for people that missed it.
Okay, thank you, everyone.
Okay, thank you so much, everybody.